I'm Dr. Finnebail presenting the second lecture. Just a reminder that we will emphasize core concepts during the PowerPoint presentation, but please refer to the study guide for the chapters as well as work through the case study and multiple choice questions to ensure that you've mastered the work. You need to go through the textbook to get more detail about all the things that we will discuss in this session. In this session, we will deal with a few genetic disorders. We will look at infant feeding and nutrition, which is of particular importance in infancy. Infections in the neonates, which can have detrimental effects to their long-term outcome as well as their short-term outcome. Then we will look at a few factors regarding preterm and low birth weight infants, and we will talk about neurodevelopmental care and how the neonatal environment impacts on the baby's development and outcomes. Human genetics is a very interesting field of study, and it is a rapidly expanding field with understanding of chromosomes, genes, and mutations that can cause genetic disease. You can often now give answers to parents who previously were just faced with uncertainty. Genetic testing plays an important role by ensuring an answer and to help with family planning for parents who are affected. You can check the parents prior to conception to check them for specific genes. You can also do in vitro testing where an embryo can be tested pre-implantation to ensure that it is healthy. You can also perform chorionic villus sampling or amniocentesis to screen a fetus while still in utero. And then many babies may be born with a genetic disease which is not identified before the baby is born, and then you can do newborn genetic testing. And some babies will also undergo screening, which will ensure early diagnosis of conditions. Genetic testing can be done on different tissue specimens. For instance, you can use blood or bone marrow, embryo, or even skin cells. So it is important to just take note of a few of the investigations that can be done to prove a genetic disorder. So firstly, you can do a karyotyping where you do a Giemsa stain of the chromosomes, and this will give you detailed information about abnormalities in the chromosomes itself. The larger chromosomes are designated by lower numbers, and then you can also see that the chromosome is divided into a centromere with then a long and a short arm. This analysis can be available as soon as 48 hours after testing, but some of the banding procedures can take up to 14 days, and you may have to wait for the result. The PCR or polymerase chain reaction has the benefit that it can amplify small fragments of DNA and can give you an answer quite quickly and inexpensively. So it's extremely sensitive procedure to do. And then you can also use the FISH or the fluorescence in situ hybridization method, which rapidly helps you to diagnose an already known DNA sequence. So here you have to be very specific about what condition you are looking for. Our individuality has to do with genetic variation, but if the variations are such, it can actually negatively impact on the normal function of cells and organs in the human body. So there are basic three categories for genetic variation. The first is structural changes, where large segments of DNA can be affected. It may affect more than one gene. There can also be changes in the DNA sequence, or there can be multifactorial changes. So if we talk about structural changes in the genome, firstly, there can be changes in the chromosomal number. The most commonly known trisomy is trisomy 21 or Down syndrome, although we also see quite often trisomy 13, which is Barthel syndrome, or trisomy 18, also known as Edwards syndrome. This you can prove on karyotyping, where you can see an extra chromosome on evaluation of the stain. Turner syndrome is an example of monosomy, where you actually have 45 chromosomes and one of the X chromosomes is missing. Other structural changes can include deletions or additions. One example of that would be Cri-du-Chat syndrome, where you have deletion on the short arm of chromosome 5, as indicated on the example in the top picture with the karyotyping. Translocations can also happen where there is a breakage of two non-homologous chromosomes, and then these broken pieces can rejoin other chromosomes. So it can be balanced or unbalanced, but in the end, with cell division, it will mean that you have more or less genetic information in the cell than there should be. One of the most common genetic disorders is trisomy 21 or Down syndrome. It's a condition that you really have to know. When a baby with Down syndrome is born, we do the karyotyping to establish how this happened. So 94% of cases, it is because of non-disjunction, which is strongly associated with advanced maternal age. If you have a younger mother, then they often have a translocation, and this will mean that they have an increased risk of a second or third pregnancy, also leading to a Down syndrome fetus and baby. Much rarer is mosaic Downs, which is only 2.5%, where certain cell lines have trisomy 21 and other cell lines are normal. As you all know, Down syndrome is strongly associated with advanced maternal age. There are characteristic features that you should know. So firstly, you usually have growth failure, and all babies with Down syndrome will have reduced intellectual capacity and mental retardation. They will have a flat back of the head, or better known as brachycephaly. The low set and small folded ears is characteristic. They can have upward slanting eyes or mongoloid slant to the eyes with epicantic folds with a short nose. They often have a mouth that looks quite small with a protruding tongue. They have a single palmar crease and can have clinodactyly with brachydactyly. Other associated anomalies are cardiac lesions, specifically atrioventricular sepal defect or AVSD, which must be excluded in every baby born with Down syndrome by doing a cardiac ultrasound. They are also prone to have duodenal atresia and also might have Hirschsprung's disease. Very importantly, on the central nervous system evaluation, they are often very hypotonic. So at birth then, very important to exclude specifically heart defects, duodenal atresia. About 10% of Down syndrome babies can have cataracts at birth. You should also exclude hypothyroidism, especially because the baby will have intellectual disability, and hypothyroidism will definitely negatively affect the outcome. And then they have an interesting disorder where they have transient myeloproliferative disorder, where you can actually see blast cells on the FBC smear. This is important as these Down syndrome babies have a higher risk of developing acute myeloid leukemia later on in life. These children have to be followed up for delayed milestones. So if you can get them into an occupational therapy program, you can actually attain motor milestones much earlier. They will have mental retardation, which might necessitate special schooling and protected living and jobs in future. And then the survival has much improved, especially since most of the mortality was ascribed to cardiac lesions. So as babies are now being operated for their lesions, they do have a much better outcome, but it depends on the associated malformations. And then just to name Cherie Brainhart, who is one of the international ambassadors for Down syndrome, and she comes from Bloemfontein, quite an aspiring lady. You don't have to know too much about trisomy 13, but if you just remember the little face on the right, they usually have quite a large nose. They might have defects in the midline, including the eyes, nose, lip, and forebrain. So if you do a cranial ultrasound, you are likely to see holoprosencephaly. They usually have polydactyly and microcephaly, and it's also associated with a single umbilical artery. The majority of these babies die early in infancy, and this is one of our indications for not resuscitating at birth if a baby has this condition. Trisomy 18 is also a lethal syndrome, with majority of babies dying in the first 3 months of life. The clinical features, again, are quite specific, with a triangular face. Pathognomonic is camptodactyly, with the little hands and fingers crossing each other. They might have rocker-bottom feet with a prominent heel and a rounded form to the foot. They also have an association with a single umbilical artery and a short sternum. Turner syndrome is a monosomy with 45 chromosomes and missing an X chromosome. These girls are usually of short length and stature, with a shield-like chest and widely spaced nipples. The ears are very low set, and they have a webbed neck, which is characteristic. Lymphedema of the hands and feet often occur in the neonatal period. And important to note that you must do a cardiac ultrasound to exclude heart lesions, specifically bicuspid aortic valves, and then as a neonate to examine their femoral pulses to ensure that they don't have coarctation of the aorta, but they definitely need to be screened by a cardiologist. The survival and the intellectual outcome is usually normal. Cardiac and renal problems can lead to morbidity and increase the risk for mortality. Doctors are very often consulted by anxious parents regarding the feeding of their neonate, their infant or toddler. It is important to meet nutritional requirements and promote growth in this very important first few years of life. It has implications for long-term outcomes as it programs for long-term health. Examples of disorders related to poor feeding is hypertension and insulin resistance. Feeding also determines the neurodevelopmental outcome and cognition. So it's important for a growing brain to receive the right nutrition in order to reach its full potential. Breastfeeding is still the standard and the feeding of choice. So breast is still best. Let's first discuss about what is normal and what can be expected regarding the weight loss and weight gain of a neonate. So firstly, once a baby is born, they lose 10% of their birth weight. This is largely due to a loss of fluid. If the baby loses more than 10%, it is likely that he has lost too much fluid and may be dehydrated. Full-term babies will then regain birth weight by day 7 to 10, after which they will gain around 200 grams per week and will follow the growth curve. Energy requirements for a full-term baby is around 100 kilocalories per kilogram per day. For preterm babies, they will regain birth weight by day 10 to 14 of life, after which they should grow at around 15 to 20 grams per kilogram per day. And again, you can plot them on the growth curve to ensure that they catch up and that they maintain the correct trajectory with their weight gain. Their energy requirements are more than in term infants because they missed out on the last trimester, where a lot of calories, calcium, and phosphate is actually built into the developing fetus. The fluid requirements needs to be adjusted according to the gestational age of the baby as well as the chronological age. These are just guidelines, so the clinical picture should be taken into account as well as the disease profile as you adjust the feeds and the fluids from on a day-to-day basis. So there's no recipe for one size fits all. You really have to examine the baby with all the parameters and then decide on how much fluid the baby should receive for that day. The nutritional requirements of the neonate are unique. So firstly, when we consider fluids, they have a much higher daily requirement than children and adults. This is due to increased insensible losses through their thin skin, but they also have kidneys that are still immature and cannot concentrate urine to compensate for fluid loss. The fluid intake must be individualized on a day-to-day basis, as the guidelines does not meet the needs of all babies. The energy and macronutrient intake is important, as babies need around 100 kilocalories per kilogram per day to grow. So the energy content of breast milk is 67 kilocalories per 100 mils of breast milk. If you then advance a full-term baby to 150 mils per kg, it will equate to around 100 kilocalories per kilogram per day. The energy in breast milk is mostly from fat, but carbohydrates also play a big role, with protein only 6%. Carbohydrates is mostly in the form of lactose. The protein is usually whey dominant, specifically lactalbumin, that is very easily absorbed. Baby feeding should also fulfill the requirements regarding minerals, specifically sodium, potassium. Phosphate and calcium is very important for the bone health, especially in preterm infants who missed out on active transport of these minerals across the placenta. Trace elements like zinc and copper can play a role in the short and the long-term health of these infants. Iron is very important also for neurodevelopmental attainment, and preterm infants are known to have inadequate stores as they miss out on the last trimester. Breast milk is low in iron, but it's very absorbable, and therefore it is sufficient for a term baby until the baby turns 5 to 6 months old. For preterm babies, we do fortify their milk to ensure that they have enough iron intake, and we give additional iron supplements until they are about 1 year old. Vitamin K is very low in breast milk, and therefore vitamin K at birth is important to make sure that their liver production of clotting factors is adequate. It is important to realize that adaptation in feeds may be necessary in certain situations. One example that we deal with on a regular basis is preterm babies. For them, breast milk, specifically raw maternal breast milk, is the most important choice, as this will protect them against infections and necrotizing enterocolitis. But breast milk is not enough to supply in the needs of a premature baby regarding the calories as well as the minerals and electrolytes. So in this case, you can fortify breast milk with a breast milk fortifier, of which we have in South Africa FM85, which is a powder that you can add. Growth-restricted babies may also fail to thrive if they do not have supplementation of their feeds. So there you can consult a dietitian to help you work out the calorie need to ensure catch-up growth. Certain metabolic and inherited conditions may need special feeding, which we will discuss a little bit later. Babies who cannot tolerate oral feeds will need total parenteral nutrition to ensure that they remain in an anabolic state. Breastfeeding is a hot topic and is discussed on various forums and social media, in magazines and in newspapers. It's important that for successful breastfeeding, you need a motivated mother supported by motivated healthcare workers in order to initiate breastfeeding within the first precious hours after the baby's birth. Please review the 10 steps to successful breastfeeding. You must know them. The physiology of lactation is really important. So the infant must suckle on the breast, which will then ensure that all the hormone systems come into play. Increased production of oxytocin by the posterior pituitary gland will lead to smooth muscle contraction and ejection of the milk. With suckling, there's also an increase in the prolactin from the anterior pituitary gland that will ensure that the milk glands are stimulated to produce enough nutritious milk. The higher centers do have an important role to play, and in the end it becomes a reflex that when a baby is crying, the higher brain centers are already activated and all the reflexes come into play. However, this can also lead to problems with breastfeeding. If the mother is in pain or under stress, it can actually suppress the higher brain centers and negatively feedback with inhibition of milk production. There are very definite advantages for the breastfeeding mother. Firstly, it's a sense of pride and achievement when you get to do it right. You are the only one that can provide for your baby, and this is very good for mother-infant bonding. Getting to know your baby, breastfeeding through the night, all of that time spent is important for the mother and infant to get to know each other. It will help with weight loss in the mother because it takes quite a lot of energy. Breastfeeding is a very convenient way of feeding your baby, as breast milk is always readily available at the right temperature. You don't have to sterilize bottles and worry about mixing and getting the temperature correct, etc. So it can also lead to amenorrhea and is a natural way of contraception to delay the next pregnancy. However, please ensure that the mothers use appropriate contraception and not just rely on breastfeeding, as many people have fallen pregnant while breastfeeding their babies. It will lead to contraction and involution of the uterus. Obviously, it has a huge financial benefit. Infant feeding is very, very expensive, and you must also take into account that you have to buy bottles and teats and sterilize it, so that all adds to the financial burden. Breastfeeding can continue despite the mother going back to work, so the mother can still express breast milk for the day and then breastfeed once she is home at night, or she can then mix feed by giving formula feeds during the day and then breastfeed at night. Obviously, this is not appropriate for HIV-exposed babies, in which mixed feeding should be avoided. It also has certain health advantages regarding cancer and prevention of osteoporosis. There are also many benefits of breastfeeding for the baby. Firstly, it provides adequate nutrition for the growing infant, and it also adapts to the needs of a growing baby. So the nutritional requirements are met. There's also an advantage for intellectual attainment, and studies have shown that the babies might have a higher IQ if they were breastfed than when they were formula fed. It is anti-infective with less risk of developing gastroenteritis, otitis media, and pneumonia later in infancy. It is anti-allergenic, specifically also causing less cow's milk protein allergies when the babies receive breast milk. It protects against certain illnesses, and then there's also less risk for sudden infant death syndrome. It decreases the likelihood of infant obesity and therefore also subsequent less risk for type 2 diabetes, hypertension, and hyperlipidemia. Neonates have poorly developed immunological systems with increased risk of developing early onset and late onset sepsis. Breast milk is protective as it has many anti-infective properties which can protect the newborn. So firstly, secretory IgA, which coats the gastrointestinal system, prevents the entrance of organisms through the gastrointestinal canal. There are also live cells in breast milk, namely macrophages, polymorphs, T and B lymphocytes. Lysozyme acts to lyse the E. coli cell membrane, so it's protective against that. Lactoferrin binds iron, and certain bacteria actually use iron for their metabolism and to reproduce. So if the lactoferrin captures that iron, then it also limits the growth of the organisms. There are also antiviral properties, specifically with secretory IgA and interferon. And then very important to realize that breast milk have live probiotics in them with lactobacilli, and these then discourage the growth of pathogenic organisms. The end benefit is then less gastroenteritis, risk of NEC is decreased, less otitis media, sepsis, and even meningitis if a baby is successfully breastfed. There are a few contraindications for breastfeeding. In maternal causes, it might be an acute illness. A mother admitted in intensive care might not be able to breastfeed, or if she herself has an infection, it might be a contraindication. Chronic illness, especially where the mother's feeding state is poor, such as chronic renal disease or heart lesions, etc., it might not be appropriate for her to breastfeed. Breast infection or an abscess might be a contraindication, and sometimes it is just temporary, and the mother can go back to breastfeeding after the infection has resolved. In HIV, again, if the mother is of low risk, the focus is now on treating the mother so that her viral load is lower than detectable limit, making it safe for the baby to breastfeed exclusively. In mothers that are high risk, HIV or end stage, it may be necessary to discourage breastfeeding and rather than go to formula. Mothers with illicit drug or substance abuse, it might not be appropriate, as well as certain conditions where mothers use medications that are contraindicated for newborns, such as mothers on lithium. In infants who are acutely ill, they may not tolerate breastfeeding. This is usually then resolved, and then the baby can continue. Mechanical problems, so certain babies might have a cleft lip or palate, which makes it impossible for them to create a vacuum and suck efficiently. So those babies might then benefit from express breast milk via another route. Metabolic illness might be a contraindication. Babies may not be able to tolerate lactose or some of the properties of breast milk, and therefore will be better served by using a specialized formula. It is important to pay specific attention to the technique of breastfeeding, and mothers should be prepared antenatally and know what to expect once they start breastfeeding. The initiation of breastfeeding should happen soon after birth, specifically in the first hour of life when the suck reflex is quite strong, after which the baby can then feed on demand. Special attention has to be given to correct positioning of the baby, and the baby should always lie with the body turned towards the mother so that the baby is in a lined position. The baby should latch on the breast by stimulating the rooting and sucking reflex. When the baby opens the mouth, the baby should take the areola and the nipple, and with the lips curled outwards, and this will then enable the baby to suck and by creating a vacuum. And then when the baby is taken off the breast, it's important to release the vacuum by inserting your finger and not to pull the baby off the breast, as that can cause injury. If the mother is unable to breastfeed for whichever reason, one will have to then resort to formula feeding. So remember, successful formula feeding is better than unsuccessful breastfeeding. So it's no need to stress out the mother. If there is a contraindication or if there is poor milk production, you can always go to formula. Firstly, please avoid using full-strength cow's milk in babies of less than a year. This is actually absolutely contraindicated. The reasons for this are that firstly, it has low iron content of poor bioavailability. There are also much higher levels of protein, sodium, potassium, calcium, and phosphate compared with human milk, which increases the renal solute load and can actually lead to metabolic acidosis. It is also lacking in certain vitamins and fatty acids, and in children it can also lead to cow's milk colitis with chronic microscopic blood loss that can contribute to iron deficiency anemia. So please avoid this in babies younger than a year. When formula feeding a baby, it's important to realize that most of these formulas are cow's milk based, and it's also called breast milk substitutes because the golden standard still remains breast milk. So most of the formulas try to get as close to the composition of breast milk as possible. You can give it as a powder formula where you add powder to boiled water, or you can have a ready-to-feed formula that you don't have to reconstitute. In the first 6 months, you will use a starter formula, and after 6 months, the follow-on, which is more suitable for the growing infant. When talking about the cow's milk-based formula, it's important to realize that the protein is modified to be more whey dominant, which is much more digestible than casein. But there are some formulas that are more suitable for hungry or older babies, which are casein dominant, such as lactogen. For the fat, it's important to include long-chain polyunsaturated fatty acids, or LC-PUFAs, and then the omega-3 and omega-6 to support the development of the brain, retina, and neurons. Carbohydrates, lactose is the main carbohydrate used in formula, which then needs lactase enzyme, which occurs on the tip of the villi to digest the milk. For premature babies, raw maternal breast milk still remains the best choice, especially as it reduces the risk of developing necrotizing enterocolitis. But we do have to add the breast milk fortifier to attain all the caloric needs of a premature baby. For this reason, premature babies have formula that is specifically adapted for their unique needs and produces higher protein to enable the lean growth of the baby. It also has extra minerals, and specifically calcium and phosphate, which is lacking in breast milk, is already included in preterm formulas. It also has extra vitamins and might be supplemented with iron. There are a few special circumstances and conditions in which specialized formula may be indicated. And few of these conditions would be a baby with allergy or intolerance of cow's milk, goat's milk, or even soya milk, in which hydrolyzed or partially elemental feeds may have to be used. Here there are modifications to the protein, carbohydrates, and fat to break them down and prevent further intolerance to these elements. In fat malabsorption, the elemental or partially elemental feeds also break down the lipids to fatty acid level to avoid further malabsorption. In a baby with lactose intolerance, you can use lactose-free formula. We don't see sucrose and fructose intolerance too often. And then in galactosemia, a lactose-free milk would be indicated as the babies have a buildup of galactose, which is then injurious to the brain and gives a very poor outcome. In inborn errors of metabolism, we suggest you consult with a specialized dietitian because very specialized milks may then be indicated. When feeding the preterm infant, it's important to consider a few factors. Firstly, what are you going to feed the baby? How much? What is the volume that you're going to administer? And then how is the baby going to get the milk? So firstly, when we talk about what to feed, we have indicated repeatedly that expressed breast milk is the best choice even for preterm infants. The second choice would then be pasteurized donor breast milk, which is indicated for babies less than 1.8 kilograms with a specific purpose of preventing necrotizing enterocolitis. Formula should always remain the last resort. When you consider the volume, it's important to individualize with every baby and consider the gestational age, the birth weight, and the age of the infant, as well as the clinical condition and illness profile. Firstly, you will consider the volume, which is your maintenance required for the day, and then you decide on how much milk you would want to administer. So firstly, you may not advance with more than 30 ml per kilogram per day in a preterm baby. The rest of the fluid will be given as daily maintenance intravenously. So for instance, if you have a baby that weighs a kilogram, 30 ml times 1 per day means that you want to advance with 30 ml over the course of a day. And as we feed generally 3 hourly, it will mean that 30 divided by 8 feeds, you can advance with 3 to 4 ml per feed. The next day you need to check the tolerance. Did the baby tolerate the milk well? And then also consider the clinical condition, if there are any signs of abdominal distension or vomiting, you might have to reconsider your feeds. It's also important to indicate to the nursing staff on how you expect the baby to take the feed. So in babies less than 34 weeks, they have a very poor suck reflex, and therefore nasogastric tube feeds will be indicated. It's a very complex process to coordinate sucking, swallowing, and breathing all at the same time. So in small babies, as soon as they have a good suck reflex, you can start cup feeding them, which they take really well. And from here, you can then transition to breastfeeding. Bottle feeding may also be an indication, especially if the baby is not going to breastfeed and if the baby obviously is more than 34 weeks with a good sucking reflex and a stable clinical condition. Total parenteral nutrition aims to give the baby all the carbohydrates, fats, proteins, electrolytes, minerals, and even vitamins that the baby needs to not only grow but to thrive. But it's not the preferred method of feeding, and there are very specific indications for administering total parenteral nutrition. So firstly, in preterm babies, less than 30 weeks and or less than 1,000 grams, you can already start TPN on the first day of life to ensure that the baby has all his caloric needs met. In preterm babies that are older at 30 weeks but unlikely to be on full feeds by the 7th day of life, you can also start TPN to make sure that he doesn't fall behind. In babies with severe intrauterine growth restriction and abnormal Doppler studies, they do have an increased risk for necrotizing enterocolitis because of relative underperfusion of the gut intrauterine. So for these babies, it might also be indicated as you would slowly advance the feeds and check the tolerance. In babies with necrotizing enterocolitis, it is part of the management plan to keep the baby nil by mouth. Therefore, the baby will not be receiving milk for anything from 3 to 14 days. In this period of time, obviously the baby needs to remain in an anabolic state, and TPN can help to feed the baby and fight off the infection. Babies with gastrointestinal tract anomalies such as duodenal atresia, jejunal atresia, or anorectal malformations might also be nil per os for prolonged periods of time, especially when they have to recover from their surgery, and therefore TPN is also regularly prescribed for them. The problem is that we have to administer TPN through preferably a central line, which increases the risk for nosocomial and central line associated infections. You can also use a long peripheral line, and in extenuating circumstances a peripheral line. But if the line infiltrates, it can actually lead to significant injury of the tissues. The most common complications seen with the administration of TPN, as I already mentioned, is infection, specifically because of the insertion of central lines, but also due to the composition of the TPN itself. There might also be significant tissue injury if the drip infiltrates, with ulceration that might even need plastic surgery. In prolonged use, in babies specifically using TPN for more than 2 or 3 weeks, as we often see with babies with gastroschisis, they might develop a hepatitis picture with cholestatic jaundice. Then glucose disturbances are common, so they can either become hypo or more commonly hyperglycemic, and therefore the glucose has to be checked regularly. It might lead to metabolic disturbance, and then the baby should be evaluated for hyperammonemia, where the protein can actually then lead to high levels. And fat accumulation can happen in the lungs. Babies can also be checked for metabolic acidosis, and then venous thrombosis might also be a problem due to the phlebitis. Vomiting must be one of the most common feeding disorders that you will encounter, and parents are often very, very concerned. So firstly, positing is something different from vomiting. It's where babies have small spills of feed, and this can be considered normal as long as the infant is healthy and picking up weight. But other causes might include, then for vomiting specifically, non-organic causes such as overfeeding. Every time the baby cries, the mother tries to soothe the baby with a bottle or the breast. And then the babies can also be overstimulated. So obviously if you're jiggling the baby on your knee, the overstimulation can actually then cause vomiting. And then if a baby cries, especially when they gulp a lot of air, the stomach can be very distended and then they can vomit. So be on the lookout for these few common causes. More concerning are the organic causes for vomiting in the neonatal period. Firstly, it can be a non-specific sign of infection, and a septic screen is then indicated to ensure that the baby doesn't have a sepsis. It might also be a symptom of a baby, especially a preterm baby, with necrotizing enterocolitis, where they might have feeding intolerance and ileus leading to vomiting. So you have to exclude that. And then it might be a sign of meningitis with meningeal irritation or raised intracranial pressure. The babies might then vomit. Gastroesophageal reflux, also a big problem in newborns and quite difficult to manage. It might necessitate referral to a pediatrician, especially if the baby has failure to thrive. In young babies, you must also be on the lookout for bowel obstruction and surgical conditions such as duodenal atresia, and in this instance the color of the vomitus is very important. So any bile stained vomitus would indicate a high obstruction. But the babies might also suffer from a ileal or duodenal atresia, in which the vomiting can then occur a little bit later on in day 2 or 3 of life. Feeding intolerance, a very vague term, which also just means that the baby is not tolerating the feeds well. And again, the differential diagnosis is quite wide, and you will have to start and firstly exclude sepsis. And here special investigations would be indicated to screen for sepsis, to do an abdominal ultrasound and see if you can see the problem. So again, just a reminder, if there are any green aspirates, consider acute surgical conditions, such as a baby with Down syndrome, where duodenal atresia is pathognomonic with Down syndrome. It must be very high on your differential list. The immune system of the fetus and the neonate is very immature, and therefore all neonates are deemed to be immunocompromised. When considering the developing immune system, it's important to indicate the differences between the innate and the adaptive immunity. So firstly, the innate system is non-specific and has an immediate effect. One can consider the physical and the chemical barriers that is actually naturally protective against invasive organisms. Skin health is very important for newborns to maintain a good skin barrier and prevent injury to the layers. Will also then protect the baby against infections. Stomach acid as well kills off pathogenic organisms in the stomach, which is one of the biggest contact areas with external environment. Internal defenses includes both the humoral and the cellular defense. So the humoral defense will be the complement system that has a cascade of events to protect the baby against pathogenic organisms by causing lysis of cell membranes. And then you have lactoferrin, for instance, which is present in human milk and which binds iron and reduces the growth of E. coli. Another example would be lysozymes that is found in tears, saliva, and also neutrophils, which have an antibacterial activity. The cellular response are mostly phagocytic white cells, which includes cells like the neutrophils and macrophages, which can then adhere to bacteria, ingest them, and also then lyse them and kill them due to enzymes and free oxygen radicals that are released. The adaptive immune response, on the other hand, is very specific, and this has a delayed response. So the two systems here is the B lymphocytes, which will then produce immunoglobulins. These immunoglobulins firstly produces IgM, and this is already present in the fetus and the newborn, but the adult levels will only be attained at around 5 years of age, and this is to very specific organisms. The IgG is then later produced, but only reaches adult levels by 7 to 8 years. Of note here is that maternal IgG is actually crosses transplacentally and is then found in the newborn's blood. And this will protect the baby in the first 3 to 6 months of life against the specific diseases. Then you have the T lymphocyte system, where you have cytotoxic T cells, which are then produced in the fetal bone marrow and then is matured in the thymus. These are also very specific cells to kill infected cells and prevent disease in the newborn. The immune system already develops in fetal life, but it's important to know that it will only mature in a few years' time, and therefore all neonates are at increased risk of infection and they are immunocompromised. Endogenous factors that contribute to this risk is that babies have decreased levels and numbers of humoral and cellular factors or cells, but not only are there decreased numbers, there's also impaired function of these different cells. For instance, the phagocytic action is less effective in the newborn, and there's also decreased complement levels compared with adults. A few exogenous factors that needs to be taken into consideration is the breaching of natural barriers, especially the skin, which protects the baby against infections. We often breach that by invasive procedures such as taking blood, inserting intravenous cannula, and we often also damage the skin by iatrogenic means, insufficient plasters, and pulling off those delicate skin layers. The fat emulsions in TPN can also cause infection as it decreases the phagocytic function of the white cells. So it's well known that babies on TPN are at an increased risk for nosocomial sepsis. There's also a decrease in commensal organisms, so babies are born sterile, but they are quickly colonized by normal commensal organisms such as lactobacilli. So anything that interferes with this natural support of these organisms can then limit the commensal organism accretion, and therefore the pathogenic organisms can colonize and then cause invasive disease. One example of this is antibiotics. So with antibiotics, you're further killing off all commensal organisms, and then the pathogenic organisms which are resistant to the antibiotics can then flourish. Drugs that can impair the immune response, such as steroids, must be avoided. And then hyperbilirubinemia, interestingly enough, reduces immune function in several ways. So it needs to be kept in mind for babies with sepsis. A neonate with an infection can acquire such an infection in basically 3 ways. The first one is an intrauterine or congenital infection, where infectious agents can cross the placenta and cause infection in the fetus even early or later in gestation. It's important to note that fetuses that are affected early in gestation are less likely to be infected. However, the sequelae are much more severe and can lead to congenital abnormalities, versus the late group, in which they are more likely to get infected, but because all the organ systems have already been formed, they are less likely to experience severe sequelae. The second group is where a baby acquires the infection intrapartum, and these patients usually present with early onset sepsis, which is then defined as getting an infection within the first 72 hours of life. Postnatal infections are usually nosocomial and present after 72 hours, so it's also called late onset neonatal sepsis. In neonates, one should always have a very high index of suspicion regarding infection. The symptoms and signs can be very non-specific, and if there are any doubts as to whether the baby has an infection, a full septic screen is indicated. When a baby becomes ill, it's important to examine the baby again in a systematic manner, starting with a proper history and then a systematic examination, which we usually start again with anthropometry and also then add whether the baby is gaining weight or losing weight inappropriately. Then, with examination of the vital signs, you can look for derangements in vital signs. A baby with a tachycardia or even a bradycardia are ominous signs. The respiratory rate can increase, or more worryingly, the baby can also have apnea, or the baby might suddenly need oxygen, which is a new finding. You can check the saturations. Again, if a baby needs oxygen where he was previously on room air, it might be indicative of a serious underlying condition. And then also the blood pressure. So by the time the blood pressure drops and hypertension develops, the baby is already in severe shock. Together with the vital signs, also consider the intake and the output from the previous 24 hours. So check whether feeds were properly tolerated, whether the baby might have been vomiting. Check the stools and make sure that there were no bloody stools reported. Oliguria can be an indication that the kidneys are underperfused, as we would see in shock. And then hypo or hyperglycemia are also good markers to see if the baby is doing well. So if a baby is hyperglycemic, it might be indicative of a stress response. And even though you can't put your finger on it, you can still deduct that the baby is not doing well. So the general impression is very important. If a baby was previously very well and active, and you have a lethargic baby that doesn't move, obviously you will then be worried. Once you start with your specific organ systems, again you can relate all of those to possible signs of sepsis. So with the color of the baby is often, we call it a septic color, which is something between pale and jaundiced and gray. Then you know that the baby is not doing well. So jaundice is often seen because the inflammatory response can lead to release of chemokines that may cause hemolysis in the red blood cells. The babies may be pale either through anemia or because the baby is compensating by vasoconstriction to try and perfuse the vital organs, which is the brain, the heart, and the adrenal glands. When looking at the skin, petechia or purpura can be an indication of low platelets, which we often see in septic babies. There might be respiratory distress, either due to metabolic acidosis in a baby that is in decompensating shock, or it could be that the baby has pneumonia, which needs to be correctly diagnosed and addressed. Abdominal distension, we are always very conscious of the fact that especially preterm babies can develop necrotizing enterocolitis, so it's always a worrying sign if the baby is not tolerating feeds and presents then with abdominal distension. Hepatosplenomegaly is important, so to examine carefully to diagnose organ enlargement. Babies that are ill also remain lethargic or could actually also be irritable. A bulging fontanelle might be an indication of a meningitis. And always evaluate the babies for signs of septic shock with multi-organ failure. As you can see in the pictures on the top right hand side is a baby that has purpura and petechiae, and then in the lower picture a baby with a bulging fontanelle, which is always a worrying sign. When talking about congenital infections, we generally use the acronym TORCH infections to remind us of all the infectious agents that can cross the placenta and cause injury and infection in the fetal period. The acronym stands for T for toxoplasmosis. Other infections would include infections like syphilis, Coxsackie B, varicella, HIV, and hepatitis. Rubella is often seen, especially injurious in the first trimester. You have cytomegalovirus, the herpes simplex virus, and if you use torches, then syphilis can also be seen with the S. The clinical features of prenatal torch infections basically affect the whole fetus and has similar patterns for symptoms and signs that can be seen in the newborn. So things to consider would be microcephaly because of damage to the developing brain. There are three specific infections that are associated with brain calcifications. The baby might have microphthalmia and cataracts, or even chorioretinitis, for which the baby has to be examined. Congenital heart defects might result. The baby can have pneumonia because of an infection in the lungs. Hepatosplenomegaly are often seen, and then there might also be petechiae and bruising because of low platelets associated with congenital infections. Cytomegalovirus is one of the commonest congenital infections that we see in the neonatal period. It's important to note that in primary maternal CMV infection, there's about a 50% risk for vertical transmission, but this is much lower if the mother has a secondary infection, where the risk then is 1 to 13%. About 10% of infected infants will actually be symptomatic when you have a primary maternal infection, but this is very much lower in babies of mothers who have a secondary infection, where the risk is then only 1%. There's an increased risk for adverse neurological outcome, especially for a fetus infected in the first half of pregnancy. This can be seen by reduced brain growth, which then leads to decreased head circumference and is classified then as microcephalic if the head circumference falls below the 10th centile when plotted on the growth chart. Calcifications may be seen, especially in babies, again, that is infected in the first and second trimester. These calcifications are typically periventricular. Sensory neural hearing loss is also more common, and there are various other signs and symptoms that you can be on the lookout for. The babies may be small for gestational age with poor fetal growth. They can be thrombocytopenic. Hepatosplenomegaly may be common, and then you can also be on the lookout for chorioretinitis, which can negatively affect the eyes. Congenital rubella is one of the preventable causes of congenital anomalies that is associated with teratogens, in this case the rubella virus, and this means that all pregnant women should be immune to rubella or should be immunized before they fall pregnant to be immune. If a pregnant woman is infected in the first 8 weeks of a pregnancy, there is 80 to 90% chance of this fetus being negatively affected and be symptomatic. This risk drops off to 50% if the mother is infected between 8 and 12 weeks, and 20% if she is infected at 12 to 20 weeks of gestation. It is important to look at the specific clinical features that is involved, and if you look at the eye involvement, this is the only infection that will give you cataracts. Compared to cytomegalovirus and toxoplasmosis, they can also have chorioretinitis. Intrauterine growth retardation and being small for gestational age is a very important factor. And then they can also have brain involvement, specifically brain calcifications, and it also is a preventable factor in deafness. Cardiac abnormalities also unique to rubella syndrome. So all these babies with congenital rubella should be screened with a cardiac ultrasound. Toxoplasmosis is a disease that is the result of infection with a parasite, namely Toxoplasma gondii, which is commonly found in cat feces and also in contaminated food. It is important again to note that if the mother is infected in the first trimester, there is a very low risk of transmission, only up to 15%, but a high risk of damage to the developing fetus, even up to 80%. If the maternal infection happens in the last trimester of pregnancy, there's a high risk for vertical transmission, but the risk to the fetus is only 2 to 10% to actually damage the fetus. The few classical features is a triad of chorioretinitis, periventricular calcifications, and also hydrocephalus. So in this case, the head circumference will probably be above the 90th centile. Babies may be asymptomatic, and symptoms may not appear for several years, and all babies that are infected should be treated appropriately. The incidence of syphilis is on the increase, and it is one of the preventable diseases, again, for the fetus and neonate if the mother attends the antenatal clinic and she is screened for syphilis. If the mother receives her 3 bicillin doses a week apart, then the penicillin will treat both the mother and also the fetus. It is a notifiable disease, so if a baby is diagnosed with congenital syphilis, it must be reported. There are 2 ways of presentation. The first instance is early congenital syphilis, which presents with symptoms and signs in the first 2 years of life, and then the late phase where the baby still has congenital syphilis, but the chronicity leads to symptoms and signs in children older than 2 years. In the early phase, you might have skin lesions affecting the palms of the hands and the soles of the feet. The baby might have a chronic serous discharge from the nose, chronic rhinitis, which can be excoriating. Babies often have hepatitis with hepatosplenomegaly and a conjugated hyperbilirubinemia. Congenital syphilis can also cause neurosyphilis with meningitis in the newborn. And then very importantly, bony lesions can lead to a metaphyseal infection, and the limb might be so painful that there can be pseudoparalysis. It also affects the hematological system with hemolytic anemia and thrombocytopenia. In late congenital syphilis, all these early symptoms then persist and cause other problems such as roughadas around the mouth. The chronicity of the rhinitis can lead to damage to the cartilage of the nose and cause a saddle nose. There may be abnormal dentition with mulberry molars and Hutchinson teeth. It can lead to deafness. The eye should be checked for interstitial keratitis, and it might also then affect the limbs with saber shins and Clutton joints. When examining a baby for signs of early congenital syphilis, it's important to examine the mucocutaneous areas very carefully, as it is present in as many as 70% of babies. Firstly, you must look at the palms of the hands and the soles of the feet, and you may see a maculopapular rash or a bullous type of a rash that can desquamate and cause the lesions that you can see on the photo. The rhinitis might be described as chronic snuffles, where there's constant secretion coming from the nose. And then on the X-ray, you can see the bony abnormalities, specifically metaphysitis, as seen with the dark bands in the area of the metaphysis. The Wimberger sign is where the medial tibia is affected, and this can then later cause bowing of the legs. Subperiosteial reaction can sometimes be seen, and this is a very painful condition that can lead to pseudoparalysis in an infant. If the baby is not treated in the neonatal period, it can then lead to signs of late congenital syphilis in children older than 2 years. So firstly, it affects the dentition, so it can lead to Hutchinson teeth or mulberry molars. The chronic rhinitis will cause damage to the cartilage of the nose and cause a deformity called saddle nose, and the bony abnormalities can then cause a saber shin. To make the diagnosis of congenital syphilis can be quite difficult, as the VDRL, TPHA and RPR might be falsely positive due to the transplacental transfer of immunoglobulin G. For this reason, other tests might be indicated, like the fluorescent treponema pallidum absorption test for IgM and IgG. And if you do use the RPR titer, it should be 4 times higher in the baby than that of the mother to indicate that there's truly an active infection in the fetus and newborn. The treatment for syphilis is still penicillin G that may be administered intravenously for 10 to 14 days, depending on whether the baby has a meningitis or not. If the mother was inadequately treated, received her last dose of bacillin within the last month before the baby's birth, but the baby is asymptomatic, the baby might also just receive bacillin long-acting and then be followed up to ensure that there's no active disease. Hepatitis B is a disease we still see in developing countries. It's important to note that mothers who develop acute hepatitis B infection in the first or second trimester have a very low risk of perinatal transmission of around 10%. If the mother, however, acquires it in the last trimester, in the third trimester of pregnancy, up to 75% of infants will develop the disease. Although this is rarely severe or fatal, the importance is that the infant may become a chronic carrier and have a 40% risk of dying of hepatocellular carcinoma or chronic liver disease as an adult. This risk is especially high in mothers who are HBs antigen positive and HBe antigen positive. The treatment for exposed newborns is to administer within 12 hours of birth both hepatitis B immunoglobulin, which is then passive immunization, and then the active immunization in the form of hepatitis B vaccination. That will continue at the local clinic with a normal immunization schedule. HIV is an important pathogen in the perinatal period, and transmission can take place either during pregnancy, during the high-risk period of labor and delivery, or during breastfeeding. For prevention of mother-to-child transmission, it's important to check the latest South African guidelines and adhere to those. They change quite often. The focus is on treating the pregnant woman in order to protect the fetus and the newborn from HIV. Prospective mothers are checked regularly for their HIV status, and if the mother is positive or newly diagnosed as HIV positive, the mother must then start on lifelong ARTs. The monitoring of adherence is important, as the management of the neonate is dependent on the viral load and CD4 count of the mother. The risk assessment at delivery is made to decide on the prophylaxis that is suitable for that specific infant. If the mother has been on treatment for more than a month and her viral load is undetectable, then she is classified as low risk, and the neonate will then receive nevirapine for a total of 6 weeks. If the mother has virological failure, is not yet on treatment, or was started within the last month before the baby was born, or if her viral load status is unknown, she's classified as high risk. If she chooses to breastfeed her baby, nevirapine will be prescribed for 3 months and AZT for 6 weeks. If the baby is exclusively formula fed, the risk is lower, and therefore the nevirapine and AZT will be prescribed for 6 weeks. Intrapartum and early onset infection is defined as a neonate presenting with infection within the first 72 hours after birth. It's important to look for risk factors for early onset infection, so you have to start with a history. Firstly, if the mother has features of sepsis during the labor process or have symptoms and signs pointing to chorioamnionitis, the neonate is at increased risk. Symptoms and signs would include fever during her labor process, a tender uterus, or offensive liquor. In our situation, preterm labor often results from a slumbering chorioamnionitis, and all these babies should then be screened for early onset sepsis. If the mother has prolonged rupture of membranes, specifically more than 18 hours, there's an increased risk for the neonate to have an ascending infection and to be colonized and infected by the organisms found on the perineum of the mother. Frequent vaginal examinations also poses increased risk. Babies that are colonized with group B strep, or where a previous infant of a mother was affected by group B strep, can then have this very specific infection. 15 to 30% of women are colonized with group B beta hemolytic strep, which is a normal commensal organism on the perineum. 1% of colonized women will then have an infected infant that might present with a group B strep infection. The importance of this condition is that it may be fatal in up to 20% of babies. The early onset present with early onset bronchopneumonia, severe respiratory distress, and importantly, the X-ray resembles respiratory distress syndrome. So if you have a term baby with a RDS ground glass pattern on the chest X-ray, you must seriously consider testing for group B strep. The late onset variant with different strains presents at day 7 to 10 of life with meningitis, and again this can lead to severe neurological sequelae in patients with this infection. When a neonatal sepsis is suspected, it's important to do the relevant investigations to prove this infection. So firstly, you will ask for a full blood count. The white cell count is important in number, but also important to look at the differential count. For a normal baby, the white cells can be anything from 5 to 20. One would be specifically concerned if the white cell count is low, with other words below 5, as this could mean overwhelming infection or an inability of the bone marrow to supply in the white cells needed to fight off the infection. On the differential count, you can look for neutrophilia, which might be indicative of infection, but it can also go up in inflammation. Neutropenia, however, is a very strong indicator for neonatal infection and should be taken seriously. If there are immature white cells on the smear, with other words band cells, myelocytes or metamyelocytes, it's also an indication that the bone marrow is actively spitting out immature cells in an overwhelming infection. So you can work out the immature to the total neutrophil ratio, and if more than 20% of the circulating neutrophils are immature, it indicates that there is probably an infection. You can use the C-reactive protein, but other markers of sepsis are also available, such as procalcitonin and interleukin-6. The most important test probably is the blood culture, which should be done in a sterile manner to avoid contamination. An LP should be done to check for meningitis. This is specifically important as neonates don't present with the typical signs as children and adults of meningitis, so high index of suspicion is necessary. When doing a urine microscopy, it's important to ensure that the sample is sterile, therefore suprapubic aspiration or insertion of a catheter is necessary to get the correct sample. A chest X-ray and other relevant investigations may be needed. As you can see on the X-ray, this is a group B strep pneumonia, which has the typical ground glass pattern with air bronchograms that we see in preterm babies with RDS. So if you have a term baby, also screen them then for this specific infection. When you treat early onset infection, it is important to consider the possible causative organisms, and these organisms obviously grow on the perineum of the mother. So gram-negative organisms in our setting is quite common. Anything from Klebsiella, E. coli, Oxyneotobacters can be expected. Gram-positives include group B beta hemolytic strep, which, as we discussed, is a very important organism, but it could also be staphylococcal or even yeast and viral infections. Onset of antibiotics usually start with ampicillin and gentamicin. The ampicillin will cover for gram-positives and also has a bit of gram-negative cover. And then obviously the aminoglycosides like gentamicin and amikacin will cover for gram-negatives. All of these antibiotics do have side effects, so you should use them cautiously and adhere to the standard guidelines regarding checking trough levels in aminoglycoside administration on the 3rd day of life, because it can be ototoxic and nephrotoxic. Postnatal and late onset infection usually occurs after 72 hours of life, and it is most common in babies admitted to neonatal intensive and high care units. The list for risk factors for nosocomial infection is quite extensive, but the most important factors probably direct contamination. Inadequate hand washing and inadequate cleansing of equipment is one of the most prominent reasons why nosocomial infections can spread in a unit. Therefore, it's important to ensure good hand washing technique and protocols in the unit, together with the availability of soap and towels to dry your hands. Procedures that will put babies at risk are all the procedures that we need to manage these small infants: intubation, insertion of nasogastric tubes or IV catheters, as well as operations that aims to manage babies with operative conditions, can all predispose a baby to infection. Mothers should also be made aware of cross-infection, so mothers must also be counseled regarding cleanliness and especially washing the hands before expressing breast milk. Bedding and clothing should also be clean and cleansed regularly. The management of a baby with a late onset infection is always supportive. It is important to check for signs of septic shock and manage these according to the neonatal resuscitation principles, and supporting the baby's respiratory and cardiovascular systems. Regarding antibiotics, a broad spectrum antibiotic should be prescribed. One can consider the most commonly found organisms in the unit, such as Oxyneotobacter, Klebsiella, and coagulase negative staph infections. Babies are also more prone to yeast infections, especially if they have received broad spectrum antibiotics before and if they have intravenous cannulas in situ. Once the culture results are made available, one can de-escalate the antibiotics to the sensitivity, and therefore again antibiotic stewardship is very important to treat the right organism with the right antibiotics for the best duration of treatment. When a baby is diagnosed with omphalitis or phoenicitis, it should be taken seriously, as it is possible that this infection can spread to the portal vein and cause portal hypertension and septic shock. So babies should be examined very closely for signs of omphalitis by evaluating the umbilical cord that should be mummifying. If there's any offensive discharge, red discoloration, and signs of infection, the baby should be admitted and treated for the most common organisms such as Staphylococcus aureus, E. coli, other gram-negative organisms. So these babies must be admitted, screened, and receive intravenous antibiotics until the infection is cleared. The prevention of nosocomial infections in the neonatal period is a hot topic nationally and internationally because of the poor immunity of our patients. Hand washing is the single most important factor when considering nosocomial infection. Staff and visitors entering a unit should wash their hands with proper soap for at least 30 to 60 seconds, taking care to wash under the nails and up to the elbows. For this reason, no clothing should be allowed below the elbow region. All watches, rings, and jewelry should be removed, and artificial nails have been proven to lead to gram-negative infection and therefore should not be allowed in the unit. Before touching a patient, the hand should be cleansed with alcohol-based hand rub, the baby then directly touched, and then after closing the ports of the incubator, the hand should then again be cleansed. Equipment such as stethoscopes and surfaces of the unit should be cleaned regularly. Aseptic techniques should be performed during procedures, insertion of lines, intubation, etc. And especially with the placement of central lines, the doctor should be scrubbed up wearing a mask and sterile gloves and sterile techniques observed. Septic patients should be isolated from other patients to ensure that the babies don't cross-infect each other in a specific room or unit. And very importantly, overcrowding should be avoided, and the staffing ratios should be adequate to enable the nursing staff and medical staff to observe the proper infection control procedures. When you evaluate a baby's anthropometry after birth, it is important to classify the baby correctly. If the birth weight for a specific gestational age falls below the 10th centile, we say that the baby is small for gestational age. So in a baby that is not growing well in utero, the growth pattern is predictable. Firstly, the weight will fall below the 10th centile, then the length will fall below the 10th centile as the baby is not growing well, and very lastly, brain growth may be negatively affected and the baby might be microcephalic. It is important at this point to classify the baby as a symmetrical or proportionate IUGR, or then a disproportionate asymmetrical growth picture. So firstly, if you have an asymmetrical growth pattern, the weight and the length may fall below the 10th centile, but head growth was spared, and therefore it indicates that something went wrong later in the pregnancy. Compared to this, if something goes wrong early in pregnancy and it's a chronic condition, the baby will then be symmetrically small as brain growth will also falter. You have not evaluated the baby properly until you've determined a possible cause for the intrauterine growth restriction. So you can class it into three main groups, namely maternal causes, placental causes, and fetal causes. If you look at maternal causes, it could be chronic disease in the mother, like chronic heart failure or renal failure, chronic illness like HIV or tuberculosis. Placental factors might be PET, multiple pregnancies, or where there's something wrong with the placenta. And then fetal causes could include perinatal viral infections, chromosomal abnormalities, and then also if the fetus was exposed to X-rays. Associated problems should be taken into account. So if a baby is born prematurely and is small for gestational age, they will have a high risk of becoming hypothermic because of the large surface area to body weight ratio, as well as the thin, immature skin, the lack of subcutaneous fat. These babies are also at risk for hypoglycemia. As growth was faltering, there was no time to pack away glycogen stores and to have subcutaneous fat and develop brown fat. So these babies might have a problem with regulating their glucose. They are more prone to perinatal asphyxia because they were starved in utero. They might have a lack of nutrients and also oxygen, and they are more at risk than during the peripartum period. They are often jaundiced. This may be related to polycythemia, and polycythemia is a result of the chronic hypoxic conditions of a baby with IUGR. So it's very important, lastly, again, to investigate for possible causes and then to anticipate and to prevent complications associated with a small for gestational age infant. Thermoregulation is a very important aspect of taking care of a neonate, as newborn babies are extremely vulnerable to the environment. They are largely dependent on warmth and nutrition from the mother. In a baby admitted to a neonatal ward, the responsibility lies with the healthcare professionals to ensure that the baby is in a safe and warm environment in order to support their growth and development. Hypothermia, especially in preterm babies, leads to increased morbidity and mortality and should be avoided. The only exception would be a near-term or term baby with suspected hypoxic ischemic encephalopathy, where hypothermia should be avoided at all costs. This is because hypothermia can worsen the neurodevelopmental outcome in these specific group of infants. They can then be considered for therapeutic cooling to protect the brain against further injury. Babies can lose a lot of their temperature, especially after birth, and it can be as high as 0.1 to 0.3 degrees Celsius per minute unless immediate precautions are taken to warm the baby. As the condition stabilizes and the baby adapts to extrauterine life, they can regulate their temperature a little bit better if they are term, but the preterm babies are largely poikilothermic, with other words cold-blooded, and they need an external heat source to maintain their body heat, and this will then be under control of the equipment and the nursing staff and the medical practitioners looking after these small infants. You should be aware of the mechanisms of heat loss that is specific also to the neonatal period. In evaporative losses, there's a lot of heat loss when the amniotic fluid evaporates from the baby's skin, and also through the immature skin where insensible losses can occur. Convection is heat loss directly into currents of air, and for that reason it's important to check that there are no drafts flowing through the labor ward. Conduction, so that is heat loss into a cold surface, which is directly under the baby, and also to equipment, so it's important to make sure that you're always working on warm surfaces and with warm equipment. In radiation, heat loss takes place to other surfaces that are not in direct contact with the baby, and again it's important to maintain a warm temperature in the whole nursery and to protect the baby from all the other mechanisms of heat loss. Newborn babies have numerous mechanisms to try and conserve their body heat. Firstly, peripheral vasoconstriction takes place after birth, which is most visible as acrocyanosis. In stable babies, this is often seen by performing capillary refill time, where the refill time is then delayed because of the vasoconstriction. You can also identify temperature dissociation, where the baby is centrally warm but peripherally feels cold to touch. Other causes of this condition could also be shock or severe anemia, so the baby needs to be evaluated for that. Newborns can increase their heat production by increasing their basal metabolic rate, or they can increase voluntary muscular activity to a limited extent. This is possible for term babies, but due to the lack of tone and power, preterm babies may not be able to utilize this mechanism. Involuntary muscular activity, with other words, shivering, is not done by newborns, and therefore they cannot generate heat as adults can. Non-shivering thermogenesis is when brown fat is metabolized. The catecholamine surge causes breakdown of the brown fat that is stored interscapular around the aorta and around the adrenal glands, and this will then generate heat and also stabilize the glucose levels. There are numerous reasons why newborns are particularly prone to heat loss. Firstly, they have a large body surface area to weight ratio. They have limited ability to shiver, and due to a lack of subcutaneous fat, they also lack the insulation against heat loss. In preterm and small for gestational age infants, they have a deficiency of brown fat, as this takes place largely in the last trimester of pregnancy when all the stores are accumulated. Decreased glycogen stores also means that the baby will become hypoglycemic and will not have the energy to maintain their body temperature. And then just after birth, the baby is born and is wet, and therefore evaporative losses play a significant role in heat loss. We have discussed numerous ways of preventing heat loss, but again, just to make the presentation complete, remember to ensure a warm environment during the labor process. The labor ward ideal room temperature should be between 24 and 26 degrees Celsius. The radiant heater should be in a working order and should be switched on before you start resuscitating, so that all the blankets that you are working with will be pre-warmed. For the preterm babies, you can wrap the baby without drying the baby first. Wrap the baby's body in plastic and put the baby under the radiant heater. When a baby is admitted in the neonatal intensive or high care unit, the equipment that we use will help to maintain the baby's body heat and prevent hypothermia. So firstly, you can choose to put the baby in a closed incubator, which can be set on either air mode or on skin mode. When it is on air mode, the clinician is then in control of the neurothermal environmental temperature. There are guidelines for these temperatures, and it will vary according to the baby's gestational age, birth weight, and also age after birth. When the baby is on a skin probe, the incubator will then adjust the environmental temperature to maintain the baby's skin temperature at the set value of 36.5 degrees Celsius. This is less work for the nursing staff. However, if the skin thermistor detaches, the incubator will think that the baby remains hypothermic and might overheat and cause hypothermia in the infant. On the open incubator, which is a treatment platform equipped with a radiant heater, you will attach a skin thermistor to the baby's abdomen and again set the temperature at 36.5, and the radiant heater will then switch on and off to maintain the baby's body temperature as you have set it. Hypothermia contributes greatly to the morbidity and mortality, especially of preterm infants. It increases oxygen consumption, which can lead to hypoxia in babies and might necessitate oxygen support. Glucose utilization is negatively affected, and babies can easily become hypoglycemic. Peripheral cyanosis can be present, as we have said with peripheral vasoconstriction. They might have poor feeding, with feeding intolerance and vomiting. Severe hypothermia can lead to capillary leak syndromes with edema, sclerema, and in term babies they can also exhibit fat necrosis, as seen in the bottom picture, which is a very painful condition. The respiratory system can also be affected, and babies often stop breathing, so they can have apnea. It may worsen respiratory distress syndrome, as the production of surfactant can be suboptimal when a baby is hypothermic, and babies that are hypothermic might also present with pulmonary hemorrhages, which are often fatal. One of the reasons for bradycardia is a baby that is too cold, so this should always be excluded. Babies can also neurologically have an abnormal examination, being lethargic, and it can predispose to intracranial hemorrhage. Due to all of these factors, the baby might also develop metabolic acidosis. Neurodevelopmental care is the term used for different interventions undertaken in the neonatal ward in order to protect the immature brain and to promote long-term normal neurodevelopment. The aim is to reduce adverse effects of noxious stimuli such as noise, light, and smell, and to limit the amount of pain and discomfort that the baby will experience during their admission. Thermoregulation as well as overstimulation is important in order to maintain the baby's stable state and to avoid overstimulation that can overcome the baby's normal adaptive responses. As in the picture, the healing environment includes consideration of all the sensory organs of the baby, and particularly partnering with mothers of these babies to take care of their babies as they are the niche. Positioning and correct handling of babies are important. Sleep should be safeguarded to ensure that the baby gets enough rest. Stress and pain again should be minimized by ensuring limitation of procedures that can be painful, as well as administering the correct pain management strategies, which can include sucrose or even morphine in more invasive procedures. The skin should be protected, and then very important to optimize nutrition to ensure that the brain can grow adequately. In neurodevelopmental care, it is very important to support all positive interventions to decrease the stress and anxiety felt by both the mother and the infant. For this reason, the family-centered approach is a novel idea and is now being introduced in units worldwide, ensuring that the mother is available to kangaroo mother care her baby, to get the father involved to help take care of the basic needs of the infant during the admission, are all strategies to keep the baby in the niche, which is obviously in the family. This also empowers the mothers and educates them once she goes home that she's confident that she can take care of her baby.